Hatvet PHARMA welcomes you to the ocean of practical knowledge about small animal practice, that is, Hatvet's YouTube channel. We are thankful to our honorable speaker and session moderators for sharing their valuable time and knowledge with us.
Dear friends, welcome to our webinar. This is again so special webinar, which is regarding a very common clinical sign, or which sometimes during olden days we used to tell it is a disease. But now we say that it is not a disease. You know, maybe it's not a disease. It's a clinical sign. And so it is jaundice. Everybody know, not only we the vets or the homeo doctors or the human medicos, but everybody know what jaundice is. Jaundice is yellowing of the skin and the mucous membranes of the body. Yellowing. So everybody knows. So now we are going deep into jaundice in dogs and cats. Of course, as an introduction, I have told jaundice, technically we call it as Icterus. So, it refers to the accumulation of excessive amounts of bilirubin in either the circulation or the tissues. So, that is yellowishness, yellowing of the tissues. So, first of all, let us go through the bilirubin metabolism. While we go through the bilirubin, first of all, we should have to know how the bilirubin is produced in the body. We all know that we have the blood cells, and these RBCs in the blood have a longevity of almost 120 days, and after 120 days, these old erythrocytes will be caught by the reticuloendothelial system or the mononuclear phagocytic system we call, especially the spleen. It will be trapped, and the network of this MPS, the mononuclear phagocytic system, it will be broken down, and by this it will be split into the iron portion, that is a heme, and the protein portion, that is a globin. Then the heme or the iron portion is iron cannot be excreted from the body because iron is needed. So it cannot be excreted. So iron molecules, that is the heme molecules, will be further metabolized for several purposes that has to be utilized. It has to be metabolized to biliverdin, and this biliverdin will be accumulated in the tissues, in the blood, and it will be reduced to bilirubin in the canines, in the carnivores. Reduced to bilirubin. Bilirubin, as we know, it is a yellow pigment. And even, not only from the RBC lysis or the hemoglobin is formed, small amount of bilirubin can be obtained from the degradation of iron-containing molecules, especially the myoglobin, hepatic hemoproteins, etc. By metabolism of these small molecules also, some sort of bilirubin will be produced. And then this bilirubin, which is nude in nature, it will be released from the tissues into the bloodstream. And in the bloodstream, it binds to a molecule of albumin. And it is carried from the circulation to the liver. When it is carried to the liver, it is known as an unconjugated part. Not at conjugation is always done inside the cell, inside the liver Kupffer cells, hepatocytes. So all these conjugated, if this has to be carried, it has to be attached to a molecule of protein, albumin, and then it will be carried to the liver. In the liver, it is now known as the free bilirubin, or the unconjugated or the indirect bilirubin. See, if we test, we can say it is an indirect bilirubin or unconjugated bilirubin or the free bilirubin. This free bilirubin then will enter the hepatocytes. It is actually fat soluble. and there it is absolutely water insoluble. This is the problem. Since it is water insoluble, this cannot be dissolved in the urine and cannot be excreted through the urine. So the unconjugated bilirubin will never be excreted through the urine, since it is water insoluble, but it is fat soluble. And so this unconjugated bilirubin, when it reaches the hepatic vasculature, this albumin is separated and this bilirubin portion will be uptaken by the hepatocytes. It will go into the cell. Inside the cell of the inside the cells, that is hepatocytes, this will undergo transformation. We call it as conjugation. This conjugation is being done by the enzyme glucuronide transferase. So this conjugation is done by this enzyme, and after that, a salt known as bilirubin diglucuronide is formed. This bilirubin diglucuronide is known as the conjugated form of the bilirubin. So that means, see, it is so simple. Bilirubin will be converted into bilirubin diglucuronide by the enzyme glucuronidase transferase inside the hepatocyte. So that process is known as conjugation. Only the conjugated bilirubin is active. This conjugated bilirubin is then released from the hepatocytes into the bile ducts, biliary canaliculus, and excreted through the biliary system into the duodenum. Through the bile duct, it is excreted into the duodenum. And inside the duodenum, microbial activities occurs. And that is it. Through the bile duct, it is excreted into the duodenum. And this conjugated bilirubin is fat insoluble and highly water soluble. And it can be dissolved into the urine very easily. It can be filtered through the kidneys, and the urine will be containing only this conjugated form of bilirubin. Okay. And this conjugated bilirubin, while entering the duodenum, it will pass into the ileum and large intestine, and in the duodenum, it is converted by bacterial enzymes into urobilinogen. Urobilinogen, it gives a yellow color to the feces. And a little bit of urobilinogen may be absorbed into circulation and again re-excreted through the urine, giving color to the urine. That is the urobilinogen. Will be giving some color to the urine also. So that is the process of production of bilirubin and the metabolic pathways of bilirubin. There is a schematic representation, and now we know this reticular endothelial system. After that, it is excreted into the duodenum. You can see the pancreas and everything. So it is a schematic representation of all these steps which I have mentioned. And jaundice can be classified into three forms. We all know that jaundice is primarily classified to the prehepatic jaundice or the hemolytic jaundice. Then the hepatocellular jaundice or the hepatic jaundice, and the post-hepatic jaundice or the obstructive jaundice or the regurgitation jaundice. These are the three types of jaundice classified based on the phase of bilirubin metabolism. This, we generally in our clinical practice, we used to see all these types of jaundice. So this is just jaundice. While just seeing the eye which is icteric or sclera which is icteric, we cannot say whether it is prehepatic or hepatocellular or post-hepatic. While examination, we can go for examination of the sclera, the buccal mucosa, and the sclera, or even the skin. The skin can be inner side of the pinnae, the ventral abdominal skin, or even medial aspect of the thigh. So So, all the skin also can be examined for presence of icterus. First of all, let us take the prehepatic jaundice. Why should there be a prehepatic jaundice? So, why jaundice occurs? When there is tremendous amount of hemoglobin, when tremendous number of RBCs are broken down, tremendous big amount of hemoglobin will be released, and when all this hemoglobin are converted to bilirubin, this bilirubin will be giving pigmentation to all the skin, the mucosa, etc. We call it as jaundice. So first let us say what is prehepatic jaundice. Prehepatic jaundice occur when there is tremendous breakdown of RBCs inside the vessels itself. That is intramuscular hemolysis. And there will be massive amounts of hemoglobin which is released and which forms the this bilirubin. And generally the liver is usually very effective for conjugation. But when the hemolysis goes beyond a certain limit, when more amount of hemoglobin is released, when the erythrolysis goes beyond a certain limit, hemoglobin will be more tremendous in amount, and so will be big quantities of bilirubin. And so, in such patients, as when the patient is having jaundice, they will be anemic also. See, if you see anemia along with the jaundice, it is definitely a prehepatic jaundice. That is how we clinically distinguish. You go to the examination for clinical examination. Along with the clinical examination itself, we can see the yellowish discoloration with the pallor. We see the buccal mucosa that will be pallor also. If there is severe pallor with the yellowishness, it is a clear indication that it is a prehepatic jaundice or intramuscular hemolytic jaundice. And hemolytic anemia in dogs and cats are more commonly subacute or chronic, and therefore usually does not cause detectable jaundice. So, see, this occurs, a small hemolysis, etc., will not cause jaundice. Some doctors even believe that whenever there is hemolysis, immediately jaundice occurs. No, jaundice occurs when it is beyond that threshold. That tremendous or very large amount of hemoglobin is released due to intravascular hemolysis. If there is a minimal quantity of erythrolysis, this type of jaundice will not occur. So, according to theories, we can assume that when big amounts of bilirubin is released, all this bilirubin will be conjugated, but the liver fails to conjugate a very big amount of bilirubin, and so unconjugated bilirubin will be more than the conjugated bilirubin. But that is theory only. But in the practical view, when there is tremendous amount of unconjugated bilirubin, everything will be conjugated by the liver, and the hepatocyte excretion mechanisms will be more active, and almost there will be similar amount of conjugated as well as unconjugated bilirubin. That is what happening really practically in the prehepatic jaundice. So just with the amount of the level of the conjugated bilirubin and the level of unconjugated bilirubin, we cannot say whether it is a prehepatic or posthepatic or hepatocellular jaundice. We cannot say, because in all these three jaundices, there will be almost similar levels of unconjugated and conjugated bilirubin. So there is a confusion with that. Don't get confused with this clinical examination or with this interpretation only. We cannot say it is a prehepatic or hepatic or posthepatic. So we can assume so many things. Or in some phases, there will be dramatic changes. For example, in the primary phases of a prehepatic jaundice, there will be tremendous release of bilirubin, and all these bilirubin cannot be conjugated, and there will be tremendous rise or a significant rise in the unconjugated bilirubin part. So in that phase, if we get the blood and take the levels of conjugated and unconjugated bilirubin, we can say it is a prehepatic jaundice. Otherwise, in later stages, the body will be sensitized. The hepatocytes are very active, and now the hepatocytes are converting or conjugating all the bilirubin which is presented to it. And so the levels of bilirubin, both the bilirubin will be the same in later stages. So that is what is happening in practice. Practical things, practical views. So I was telling that everything depends upon the stage also. So I was again advising that we cannot assume or conclude that it is pre or hepatocellular post-hepatic jaundice from this level only. But at the same time, there will be increase in levels of both the bilirubin. So, under this circumstance, we can say in active forms of prehepatic jaundice, there will be an equal mixture of conjugated and unconjugated part of the bilirubin. That is what I was trying to tell you. Then coming to the common causes of prehepatic jaundice in dogs, we know the IMHA. The immune-mediated hemolytic anemia, it's very common. Especially it can be presented as such, or it can be associated even with tick fevers. So IMHA is very common, and it causes tremendous breakdown of intravascular RBCs. Then zinc toxicity produces intravascular hemolysis, Heinz body anemia, especially in cats. In dogs also this can happen. Very high amount of consumption of acetaminophen or paracetamol phenol derivatives can cause Heinz body anemia. So then onion toxicity, consumption of onion in dogs can cause Heinz body anemia. Then intraerythrocytic parasites, Babesia canis, Gibsoni, Ehrlichia, all these things can cause intravascular hemolysis. Transfusion reaction, it's not very common unless we do a transfusion. Then heartworms, they also can, the Caval syndrome, you know the Caval syndrome, but it is not present, the Caval syndrome is not truly present in our country, but you know, heartworm can produce intravascular hemolysis. These are all spherocytes, you can see, whenever, see in my hematology class also I have told that spherocytes, when these spherocytes are seen, see these are spherocytes. Spherocytes, and the one which we have the stoma is the stomatocytes, and the round ones are the spherocytes. And the spherocytes, presence of spherocytes always indicates in our hematology and blood biochemistry, in our hematology, practical hematology, it indicates IMHA. I have called, see already in my hematology class I have told that when there is IMHA, number one we have to look is for the presence of spherocytes in the smear. Number two is there will be high MCHC. Go to the hematology, MCHC will be high. So this is a saline slide agglutation test for IMHA. This is very commonly done. Then onion toxicity produces Heinz bodies, which are inclusion bodies, and these inclusion bodies can bring about extensive intravascular erythrolysis. Then sometimes you can go through prehepatic jaundice in cats. Mycoplasma haemophilus, the old name was Eperythron felis, Eperythrozoon felis, and this now it is come under the Mycoplasmataceae family, and it is Mycoplasma haemophilus, and mycoplasmosis in cats can produce intravascular hemolysis. FLV virus can produce hemolysis intravascular. Hypophosphatemia can produce hemolysis in cats. Then acetaminophen is a well-known toxicity in the cat. Neonatal isoerythrolysis. It is not so common in cats, but it can also happen after sucking the colostrum. Then comes the next one, the hepatocellular jaundice. Hepatocellular jaundice means it has come to the liver, there is no intravascular hemolysis, it has come to the liver, but the liver is absolutely unable completely to conjugate the unconjugated bilirubin. So we can imagine what should be the condition if you analyze what the level of prehepatic, the unconjugated and the conjugated part. The liver is unable to conjugate all the bilirubin which is received by the Kupffer cells. So what can be done? Naturally, according to theoretical arithmetics, we can see that the level of the unconjugated bilirubin rises. The level of the conjugated bilirubin will be very low. But no, it is not so. Liver is an organ which is having very high capacity of regeneration. And we all know up to even 1/10 of the liver is present. That is sufficient to do some activities. Like conjugation also can be done by this 1/10 of the tissue of the liver. So, whatever be the destruction in the liver tissues, the remaining liver tissues of the liver cells will be sufficient to conjugate the excessive producing or the produced or unconjugated bilirubin. So, let it then the theory is there, the unconjugated hyperbilirubinemia occurs. But it is not the theory to work. In practical views, there will be a mixture, a complete mixture of, equal mixture of unconjugated bilirubin plus the conjugated bilirubin. That's no, it is confused. So don't get confused. In hepatocellular jaundice, if there is active hepatic degeneration, in such cases, we can go for other diagnosis of the liver diseases. Lot of things are there. Primarily, there will be hepatomegaly. There can be ascites, or you can do ultrasound, we can see the echo texture of the liver, or we can go for the blood enzymes, the hepatic enzymes, the ALT, GGT, AST, all this can be assessed to find out the condition of the liver. So there are a lot of things how to diagnose liver diseases. So hepatocellular jaundice would be expected to be associated with elevated plasma levels of conjugated bilirubin and normal and conjugated bilirubin levels of Vinod. And so, therefore, I have already mentioned that there will be an equal mixture of unconjugated and conjugated part of bilirubin. Now we can come to the common causes of hepatocellular jaundice. The common causes are toxic hepatopathy either in the dog or the cat, and hepatic neoplasia in the dog or the cat, whether it is primary or metastatic. Especially the dog can be chronic hepatitis, can be copper storage diseases. See, it's also not very common. In leptospirosis, there will be extensive damage to the liver. ICH, in infectious chronic hepatitis, adenoviral infection. Then hepatic fibrosis, or the chronic part of hepatitis, that is hepatic cirrhosis. In the cats, suppurative or lymphocytic cholangiohepatitis, idiopathic hepatic lipidosis is very common. Idiopathic hepatic lipidosis, FELV associated disease, especially lymphosarcoma. Then FIP is also very common nowadays. It's very common in cats. Toxoplasmosis, very common. Acetaminophen toxicity, also very common. Then coming to the post-hepatic jaundice. Post-hepatic jaundice means, say, there is no prehepatic jaundice, there is no intravascular hemolysis, and the liver is normal, but the liver produces and conjugates all the bilirubin and the conjugated part of bilirubin while excreting through the biliary canaliculus. There is a blockade. So we have now that produces obstruction of the jaundice, obstruction of the biliary tract, and thereby reabsorption of the bilirubin. And so it produces a post-hepatic jaundice. It can be either obstruction of the biliary tract or due to rupture of the biliary tract. That can also occur. And it can even occur from excretion of conjugated bilirubin, impairment of excretion of conjugated bilirubin into the small intestine. See, impairment of excretion can happen due to these two reasons. One is obstruction of the biliary tract. Number two, there is rupture of the biliary tract. So there is nothing flowing into the duodenum through the bile duct. So actually bile is not going into the duodenum. So what will happen? Bile has a lot of functions. The main function is the bile has bile salts and bile pigments. But the bile salt is essential for emulsification of fat. We all know it. Since the fat particles in the feces is going through the duodenum, it cannot be emulsified and the fat globules will be formed as such. And the feces will be white in color. We call it as ecolic feces. Ecolic feces. I'll show you the picture. Ecolic feces. And so the hepatobiliary system will be normal. There is no dysfunction of the liver. Develops gradually over a period of days or even weeks. So jaundice, secondary to a biliary obstruction, is initially associated with elevated plasma levels of conjugated bilirubin and normal unconjugated bilirubin levels. This is the only place where you can see the abnormality in the two fractions of the bilirubin. Here, because the liver is normal, normally the bilirubin is produced and the unconjugated portion has come here. The conjugated portion is also there and the conjugated portion is more. And the conjugation portion naturally should be flown to the duodenum, but it is not flowing. All the conjugated portion will be sequestrated inside the biliary tract. Sometimes rupture occurred, bile is found free inside the peritoneal cavity, and all this bile contains more portion of conjugated bilirubin and normal levels of unconjugated bilirubin. So whenever you are in any stage of the disease, whenever you are checking the bilirubin and the conjugated part is more, we can say it can be post-hepatic jaundice or with a normal level of unconjugated part. The liver, since the liver cannot excrete excess bilirubin via the biliary tree, conjugated and then unconjugated bilirubin increase within the hepatocytes and spill into circulation. That is what we told. It cannot excrete more, it will be spilling into circulation. And the rupture of the biliary tree also will produce the same effect. During the rupture also, this bile cannot be passed through the bile duct. Bile duct will be completely free. It will be spared and all the bile will be accumulated inside the peritoneal cavity and absorbed in the circulation, producing hyperbilirubinemia, that is conjugated hyperbilirubinemia. These are the common causes of the post-hepatic jaundice, biliary obstruction and biliary rupture. Biliary obstruction, when biliary obstruction or how biliary obstruction occurs, can be due to chronic or acute pancreatitis. When there is severe pancreatitis, the pancreas itself, especially this is found in human beings. Human beings, the pancreas is much more bigger than the dog or the canine pancreas. So even in the canine pancreas also, if it is acute pancreatitis, it will undergo edema and there will be increase in size. It can push or it can compress the biliary tract, thereby producing physical obstruction of the biliary tract, producing post-hepatic jaundice or neoplasia. Neoplasia, maybe intestinal neoplasia or pancreatic neoplasia or hepatic neoplasia, which produces true obstruction. If it is an intestinal neoplasia, it can compress the biliary tract, or pancreatic neoplasia can compress, or intrahepatic neoplasia can produce complete obstruction of the biliary tract, or even a stone inside the biliary tract can produce obstruction, cholelithiasis, or even inspissated bile. Sometimes bile becomes precipitated or inspissate due to chronic accumulation or precipitation. So such type of things are there. So we have to think of all this biliary obstruction. Then sometimes biliary rupture occurs. If this bile will be accumulated inside the peritoneal cavity. And so what will happen? This bile will be, actually this bile is an irritant. It will irritate the peritoneum. It can even cause severe peritonitis because bile, it can produce chemical peritonitis. And this bile will be reabsorbed, producing conjugated hyperbilirubinemia. This is a colic feces. Due to the absence of bile, there is no fat emulsification. This is a colic feces. And see, when we are examining the stools, we have to think of three things: the creatoria, amyloria, and steatoria. When we examine the stool, we examine for creatoria, we examine for steatoria, and we examine for amyloria. What is creatoria? Presence of undigested muscle fibers in the feces. What is amyloria? Presence of undigested starch molecules in the feces. Then what is steatoria? Presence of undigested fat globules in the feces. This is a typical steatoria, where you can see even a colic feces or even steatoria can occur. That is what I was going to tell you. Steatoria also can be a symptom of obstructive jaundice, where there is no bile in the biliary tract, in the duodenum. And there are some clinical signs associated with the jaundice. And tissue jaundice is obvious on physical examination and usually associated with the marked hyperbilirubinemia. Generally, if the total bilirubin is more than 2 or more than that, 2 milligram per deciliter or more than that, then only the clinical jaundice or detectable jaundice occurs. Otherwise, sometimes if it is below 2 even, we can see sometimes a mild, very mild Icterus. And hyperbilirubinemia is therefore detectable as a biochemical abnormality long before the tissue jaundice becomes apparent. Sometimes if we take the blood and we are going to test the blood, we have taken the EDTA, anticoagulated blood, and we are going to conduct the CBC, and we are kept there, and after half an hour we are going to test it. So by that time the RBCs is settled down, you can see the plasma. Plasma will be highly icteric in nature. So from that it is a clue that there is jaundice. Or if you take the clotted blood, the clot is inside, after half an hour you can see the clot and the serum can be seen separate. The serum is highly icteric. You can say that the animal is in jaundice. Obviously from the very first inspection of the serum itself or the plasma itself we can see that. And since I already told that the conjugated bilirubin is water soluble, but conjugated bilirubin is water soluble, highly water soluble. That is why in the urine only the conjugated bilirubin is seen, and as well the unconjugated part is water insoluble. It cannot be seen in the urine, and it diffuses into the tissues much more readily than the unconjugated bilirubin. Since it is water soluble, this conjugated part of bilirubin, it is highly water soluble, and when it is soluble in all the body fluids. So wherever the body fluids are everywhere in the body. Wherever the body fluids go, it will be deposited and gives yellowish discoloration to all the tissues. And all the yellowish discoloration of the tissues in jaundice is due to the conjugated part. And the that is what the just opposite to that. If it is the unconjugated part, tissue jaundice is detected at lower total serum bilirubin levels than the prehepatic jaundice. So we can assume when there is actual icterus of the tissues like the skin or the mucosa, it is a conjugated part. See, jaundice can be detected by inspection of the sclera, inside of the pinnae, the back of the throat, and the skin of the ventral abdomen, even the skin of the medial thighs. And since the renal threshold, the kidney threshold or the renal filtration threshold of bilirubin is very low, especially in the dog and human beings, it is very low. And so, if the mild quantities, small quantities of bilirubin can be freely excreted into the urine through the kidneys. And so, traces of bilirubin in the urine of the dog as well as the human being is normal or very common and normal. But in the cat, the threshold is very high. The threshold of the kidneys to the bilirubin is very high, and bilirubin normally cannot be excreted through the kidneys and be present in the urine. So whenever you see that it is present in the urine, it means that there is clinical jaundice because high amounts of bilirubin is present in the blood plasma. That is why slight traces are found in the urine because the threshold is very high. So theoretically, patients with acute hemolysis and early prehepatic jaundice, where there is elevated free bilirubin and normal conjugated bilirubin levels, may not have bilirubinemia since free bilirubin is bound to albumin and cannot enter the urine. So that is all regarding the low threshold in the kidneys in the dog and the high threshold of bilirubin excretion or filtration in the cat. And bilirubin, there is a jaundice with biliary obstruction or rupture, or if there is a normal liver, it will be having a good prognosis. Let it be prehepatic jaundice or let it be a obstructive jaundice. So let the biliary tract is having a slight rupture, it is having a good prognosis. So, profound elevation in unconjugated bilirubin can cause neurotoxicity and nephrotoxicity. So that is known as kernicterus. Sometimes we have seen this. I have seen one case of a kernicterus where there is unconjugated hyperbilirubinemia that itself can produce a neurotoxicity symptoms like shaking of the head and nephrotoxicity even. That is known as kernicterus. And we can go to the signs of prehepatic jaundice. The patients with obvious prehepatic jaundice usually have severe intravascular hemolysis. Of course, we know it. And the clinical signs of anemia, weakness, pale mucous membranes, tachycardia, tachypnea, and they tend to predominate. And severe intravascular hemolysis may cause hemoglobinemia and hemoglobinuria. It produces there is hemoglobinuria producing a typical port wine urine. Now we will show you just see how the port wine urine what the port wine looks like. This is actually the port wine, and the urine also will look like this. So port wine is, since this is the port wine, clear port wine, and this is the port wine type of urine. It's a port wine urine. So now you can see what is the similarity between the port wine, real port wine, and the port wine urine. Here also you can see the normal urine, where the port wine urine, everything you can see here. Then coming to symptoms of the hepatic jaundice. In hepatic jaundice, we all know what will happen. There is severe hepatitis or hepatic dysfunctions. Since the patients with jaundice due to hepatic disease invariably have profound hepatic dysfunction, jaundice usually occur concurrently with other signs. Definitely, we know the other signs like weight loss, anorexia, ascites, vomiting, diarrhea, polydipsia, polyuria, coagulopathies, and hepatic encephalopathy. All these can be seen, or it can be all, maybe all the signs, or can be some of the signs, or can be one or two signs. And coming to symptoms of a post-hepatic jaundice. Post-hepatic jaundice, I already mentioned that, can be due to true obstruction due to swelling of the pancreas or something like that, due to true obstruction of the biliary tract, or can be a rupture of the biliary tract. So patients with biliary obstruction unaffected for a long period, days to weeks, and number one clinical sign is echolic feces. Pale gray feces suggests complete obstruction. Since the bile acids are excreted to the duodenum via the biliary tree and needed for fat absorption, biliary obstruction can cause fat malabsorption and steatorrhea. If there is no bile, the bile only consists or contains these bile acids and the bile salts. So there will be steatorrhea or greasy feces. And we know there are two types of vitamins. The vitamin A, D, and K are the fat-soluble vitamins, and the vitamin C and the B complex are water-soluble vitamins. Of course, when there is fat malabsorption, there will be reduced fat in the body, and all these vitamins which are derived from the diet, they cannot be dissolved, and there will be deficiency of these vitamins, especially A, D, and K. Vitamin A deficiency, especially vitamin K deficiency. And when there is vitamin K deficiency, definitely bleeding disorders occur. So that is why patients with chronic biliary obstruction are therefore prone to bleeding disorders due to the depletion of active forms of vitamin K. If vitamin K is derived from the diet, and if it cannot be stored inside because there is less amount of fat due to reduced fat absorption, malabsorption. So vitamin K deficiency occurs. Patients with biliary obstruction due to acute pancreatitis may exhibit anorexia, vomiting, diarrhea. We know all the symptoms of pancreatitis: abdominal pain, acute abdomen, swollen abdomen, etc. And obstruction secondary to chronic pancreatitis with pancreatic scarring or abscessation, in contrast, may occur months or even years after the last clinical apparent episode of the typical pancreatitis. Scarring. Then there is, in human beings, there is another disease known as a CCP, chronic calcemic pancreatitis. CCP immediately changed to pancreatic adenocarcinoma. That is why it is a transformation, dangerous transformation in human beings. And so even CCP produces swelling of the very hard pancreas, and even pancreatic adenocarcinoma, there will be swelling, and there will be biliary obstruction, obstructive jaundice. I have seen one case. And some cases remain subclinical in pancreatitis, and jaundice is the only present complaint. And in patients with biliary obstruction secondary to neoplasia, maybe hepatic neoplasia or pancreatic neoplasia, there will be signs of neoplasia like anorexia, weight loss, etc. And since the jaundice associated with the biliary rupture occurs following the resorption of bile pigments, in rupture there will be complete rupture, and it will be free. The bile will be free. On ultrasound you can see the free bile or the free fluid inside the peritoneal cavity. That's what is inside the peritoneal cavity, and you can see all these bile which is found free inside the abdominal cavity will be resorbed, and the patients of this form of post-hepatic jaundice invariably have marked ascites also. And in cases of rupture, definitely this bile will go and irritate the peritoneum, producing acute chemical peritonitis, producing severe anorexia, pyrexia, severe abdominal pain, etc. Then diagnosis. Diagnosis of jaundice is through hematology, serum biochemistry, urinalysis, and gross inspection of the feces and microscopy. Coming to the hematology part, Hepatology, we all know, if it is a prehepatic jaundice, there will be profound anemia. There will be total RBC count will be low, hemoglobin will be low, PCV will be low. So all these things. Hepatology alone is often enough to diagnose prehepatic jaundice. Yes, prehepatic jaundice is very easy to diagnose. Jaundice and anemia, it is prehepatic jaundice, nothing at all. Since hemolysis must invariably be severe before jaundice becomes apparent. PCV is generally less than 15 to 20% in the dog, 10 to below than 10 to 15 in the case of cat. Since less severe anemia is likely to cause clinically detectable jaundice, mild to moderate anemia in a jaundiced animal may be due to disease process causing the jaundice, of course. Then coming to serum biochemistry, we can go for all the liver tests, etc. Biochemistry may suggest ongoing hepatic damages, elevated ALT, AST, etc., GGT, all those things we know. Hepatic dysfunctions like hypoalbuminemia. Albumin is synthesized from the liver, and there will be chronic hepatitis, there will be hypoalbuminemia, hypoglycemia, and decreased urea. All these are seen in chronic hepatic dysfunction. Others, if it is pancreatitis, can be amylase, lipase, total serum bilirubin, all these can be analyzed. Then coming to the urinalysis in jaundice patient. See, we have mentioned that the dogs have a low urinary threshold, the renal threshold for conjugated bilirubin, and small amounts of bilirubin can be seen as bile crystals and normally found in the concentrated urine of dogs. And since the canine renal tubules can conjugate some bilirubin, bilirubinemia may be also potentially occurring with prehepatic jaundice even through protein-bound unconjugated bilirubin. But cats, they have a very high renal threshold for conjugated bilirubin, and so detection of any amount of bilirubin in cat urine is always clinically significant and should be investigated carefully. That is what we have to keep in mind always. In the cat urine, if you find bilirubin, it is highly significant and dangerous. It shows that the cat is having jaundice. That's what I'm meaning. And if you coming to the examination of feces, we know alcoholic feces. Alcoholic feces, white or grey colored feces due to the absence of bile salts and pigments, or steatorrhea due to faulty emulsification of fat, highly suggestive of post-hepatic jaundice due to complete biliary obstruction. And a partial biliary obstruction is usually associated with normal fecal color and composition. And coming to the diagnostic features of prehepatic, hepatic, and post-hepatic jaundice. After evaluation of the hematology, blood biochemistry, urine, and feces, the doctor should approach very cunningly to jaundice, which should be facilitated by a deep understanding of the diagnostic features of prehepatic, hepatic, and post-hepatic jaundice. This is very important. There is no escape. We should have a clear idea of prehepatic, diagnosis of prehepatic part, diagnosis of hepatocellular part, diagnosis of post-hepatic part. Then coming to the prehepatic jaundice, the prehepatic jaundice is invariably associated with severe intravascular hemolysis. We know hemoglobinemia and hemoglobinuria. In the dog, prehepatic jaundice is usually due to severe acute forms of IMHA, whereas in the cat, the most common causes are the prehepatic jaundice, including IMHA or Mycoplasma haemophilus and FELV. There are some specific tests in the small animals with the prehepatic jaundice. Visual inspection of the serum and the urine color. Of course, I already mentioned it. A rapid slide agglutation test, or Coombs test, for the diagnosis of IMHA. But in the field we used to do the saline slide agglutation test. Then examination of red cells. Or in the field you can go for, I have already mentioned about the detection of spherocytes in the blood smear. Then this MCHC. These two indicates IMHA. Examination of the red cells, examination smear for Mycoplasma haemophilus in the cat, And serological testing for FEV is a lateral flow kit. Then blood smear examination, spherocytes and high MCHC and IMH. Then some other less common forms of hemolysis occurs, such as the Heinz body anemia. But the onion toxicity, even though it is the onion, how the dog will eat onion. Onion is having a pungent odor and taste. The dog will not generally eat onion, but somehow it happens to eat more amount of onion, especially raw onion. It produces Heinz body anemia. Acetaminophen toxicity, zinc toxicity is very rare. Then hypophosphatemia in the cat, it induces hemolysis. Transfusion reactions, neonatal erythrolysis, Cavill syndrome in the dog, especially, can usually be determined by history, routine diagnostic testing, and more specific tests such as serum phosphate, heartworm testing, etc. Of course, we can do. Then hepatic jaundice. Over half of the original function of the hepatocyte. See, we know that, in fact, even 9/10 of the liver is damaged. By that time also may not be shown, the clinical signs may not be shown. Only the 1/10 part of the liver can sometimes do its function. That is why only that is needed for the complete regeneration. So that much a regenerative tissue like the starfish, it is, we know very well. So the classical signs can be there in the hepatic jaundice, like jaundice, hypoalbuminemia, hypoglycemia, and low urea. Hypoglycemia, definitely there will be, it will be seen in hepatic dysfunction site. Liver is the seat of conversion of uric acid to urea by the enzyme uricase, which is present in the urea in the liver. And so in hepatic failure, there will be low urea level. Then standard function tests include pre and postprandial serum bile acids, of course, especially portosystemic shunting, suspicion of PSS. We can go for the estimation liver enzymes such as alkaline phosphatase, then alanine transaminase, ALT, ALP, then GGT. All these are elevated. Since ALT is a leakage enzyme because it is seen inside the liver cells. And when there is severe destruction of the liver cells, of course, this ALT will be coming out and it will be elevated. And alkaline phosphatase, GGT, in contrast, are induced enzymes, and elevations of these enzymes can occur without ongoing cell damage. These are induced enzymes. Both alkaline phosphatase, ALP, alkaline phosphatase, and GGT are induced by cholestasis and will be elevated with either in the extrahepatic or intrahepatic obstruction of the biliary canal, cholestasis. So, already in our blood biochemistry classes, we have mentioned that alkaline phosphatase is an enzyme which is produced from different parts of the body. And it is actually, the major portion is coming out from the cells or the epithelial cells lining the intravascular or intrahepatic biliary canaliculi. And so these cells will be producing or excreting this alkaline phosphatase. And when there is obstruction of the biliary tract, there will be the stasis of the bile and there will be increase in alkaline phosphatase. And so alkaline phosphatase is not liver specific because it is obviously alkaline phosphatase is formed from the osteoblastic and osteoclastic activities also. So it cannot be considered as highly liver specific. Even when we give chronic steroid administration, anticonvulsant administration, and there in young ones, when there is more bone growth, there will be more osteoblastic and osteoclastic activity producing more amount of alkaline phosphatase. So compared to the dog, liver enzymes have much shorter circulating half-life in the cat. Any elevation in the ALT or ALP in the cat should therefore is regarded as diagnostically significant, highly significant. Alkaline phosphatase and GGT are usually concurrently elevated in cats with hepatic diseases. Then clotting factors. We can go and assess if we can see, because PTT, they say prothrombin time, natural prothrombin, all these things cannot be estimated in all laboratories or all the clinics. If we can do it. Or the chronic biliary obstruction can cause depletion of vitamin K, especially vitamin K is a fat soluble vitamin. When there is malabsorption of fat, there will be vitamin K depletion or deficiency. And there will be fat soluble vitamin PT and the prothrombin time and the PTT are prolonged in post-hepatic jaundice. That is the reason. Normal PTT and PT of after supplementation with the parallel vitamin K. Of course, that is another test. We can give some injections of vitamin K, and after that PTT and PT can be taken. If it has become normal, then we can say it is due to deficiency of vitamin K, which is due to post-hepatic jaundice. And liver architecture, etc., can be assessed from ultrasound. There is a normal activated partial prothrombin thromboplastin time, APDT, is 8.9 to 18.7 seconds, and the prothrombin time is 5.4 to 11.9 seconds. So this can be assessed only in laboratories where we have these type of estimations. Then coming to the post-hepatic jaundice, it is due to extrahepatic biliary obstruction or can be even due to biliary rupture. Both causes elevation in the liver enzymes. Since obstruction has better prognosis. See, I already mentioned that if the post-hepatic jaundice is due to either rupture or due to obstruction, whatever be the cause, if it is not a cancer, it is having a good prognosis. Diagnostic tools that can be useful like serum biochemistry, elevated amylase and lipase. Then, if it is due obstruction is due to pancreatic disease, hypoalbuminemia, low urea, hypoglycemia, etc., suggestive of hepatic failure. Then the liver function tests, post-hepatic jaundice have normal ammonia intolerance. Chronic obstruction can lead to hepatic dysfunction. A response to vitamin K, you can inject vitamin K and then take PT and PTT. Abdominal radiography and ultrasonography and liver biopsy. Prognosis depends upon the cause of jaundice. If liver cancer or chronic hepatitis, then there is no escape, the prognosis is poor. If IMHI is, then the prognosis is guarded with about 2/3 surviving the initial crisis and most with the full recovery. And if there is a liver disease, the prognosis depends upon how much damage has already happened to the liver, but we do not know. And liver, as such, we know it is a highly recoverable organ. If toxicity is there, the prognosis depends upon what the toxin is. If it is, unfortunately, if it is acetaminophen toxicity in the cat, the prognosis is always guarded. We know it. If congenital conditions such as copper toxicosis, the prognosis is good. Treatment is aimed on the underlying disease. Support the system for the repair. If it is the liver, support for the repair, that is all. Vital organ repairs, attending anemias, we have to go for blood transfusion sometimes. Icterus will take a longer time. See, if the dog or the cat is recovered, the icterus will be there for a much longer time, and the dog or the patient will be normal. The icterus will be there for a much longer time. It will take a long time for the icterus to disappear. Intravenous fluids, Ringer's lactate of 5% dextrose. If RL can be given if the liver is okay, liver is normal. Then don't give sodium chloride containing fluids IV if the liver is damaged. Antibiotics, if it is a bacterial infection, you can go for anti-anaerobic antibacterial such as ceftriaxone, metronidazole, amoxicillin sulbactam, appetite stimulants, antiemetics, then antacids, digestive aids, pain medication. We will go for SAMI, adenosine methionine. It's a good liver regenerative. Then we can go for silymarin. For pain medication, we can go for buprenorphine. And let me conclude with one of my recent case. It was a 52 kilogram weighing, very huge male, 80 years old Rottweiler cross. What was on treatment against inappetence and weakness for the last 35 days in another hospital. So carefully listen to what I say. For the last 35 days, it was in some other case, some other hospital, and somebody suggested my name and they presented it to me for a second opinion. And he was a soldier, he was in the artillery, who was in the artillery for 18 years, fought for our nation several times. And I am very fond of soldiers. always respect our soldiers. He kept confidence on me and asked whether I can save the pet. And so very huge aggressive Rottweiler. And he was very sick, having severe jaundice, hepatic failure, multi-organ failure. The liver was gone, hepatic failure with the kidney failure. How I can save the pet? But I need investigations. Without that, I cannot say anything. He has all the reports, a lot of reports he has. He presented the treatment history. The patient was presented 35 days ago to a previous hospital and with vomiting and inappetence. They did all the blood tests and investigations and found slightly elevated liver enzymes and TLC. Assuming it was GI disorder, they started IV fluids and antibiotics. There was no response for a week, but symptoms aggravated. They performed all the blood tests, often at least 6 times. Total leukocytic count went down, but the animal developed Icterus. They ran all the tick fever panel and leptospirosis and found negative. Though negative in these panels, they started IV doxycycline, metronidazole, clindamycin, etc. RBC count then again dropped day by day, and hemoglobin also dropped. Bilirubin and visible Icterus increased day by day, and liver enzymes like ALT, AST, alkaline phosphatase, GGT, etc. and blood urea creatinine was tremendously elevated. Total hepatic and liver failure, hepatic and kidney failure. In that condition, he presented to me. Since there was no response in 30 days, the parent naturally got frustrated and reacted offensively to that old doctor. And after that, he came to me. The last values were as follows. He presented the last values. Like the ALT was above 300, AST was above 600, alkaline phosphatase above 1000, blood urea above 250, creatinine was 3.7, RBC was just 2.1, hemoglobin 5.5, PCV was low, PCVLT was, platelet was low, TLC was normal, DC normal, and DP above 3, and direct bilirubin above 3, and total bilirubin above 6. While it was presented to me, the board body weight was 50 kilograms, which was 52 kilograms previously. The dangerous challenge to me, I have two options before me. Either I can handle the case or I can refer to a veterinary college. Here what I did was, I accepted the challenge, suspecting IMHA. I ran, all the blood tests were done the day before that day. So I did not do all the blood tests. Just, I collected the blood just for CBC and smear study. CBC showed normal TLC and DC. Thrombocytopenia, RBC was 1.9, hemoglobin was 5.3, PCV was 15.2, MCV was high, MCH was low, MCHC was very high with ESR 126. ESR is also a critical point, it was 126 millimeter per hour. Smear examination showed leptocytes, cordocytes, and abundant spherocytes. So it was a clear case of IMHA. IMHA happened. It is IMHA, but fast ongoing intravascular hemolysis. Slide agglutination test was positive for agglutination grossly. Microscopy of the said slide shows extensive agglutination. The case was immediately confirmed as IMHA with very fast ongoing intravascular hemolysis. That I could not stop. Blood transfusion has to be immediately done. What to do? It's a 50 kg weighing dog. How to do? From where I will get this much of blood? I don't have a blood bank. I inquired the veterinary college. They said they will transfuse if proper donor is presented. See, needs approximately 23 ml per kg blood. So from where I will get such a huge giant donor? Needs 50 ml per kg blood, at least 15 ml per kg blood, that is 50 into 50, that is 750 ml, or sometimes I may need 1000 ml of blood. From where I will get? And it should be collected from a single donor. Can I collect it from any other species? How can I get a single donor which can, where 750 to 100,000 ml of blood can be collected? I cannot. From where I will get? We have no blood bank even. To get 750 ml of blood, we need a dog of at least 60 kgs. From where I will get a 60 kg weighing dog? At least, or if there is a 60 kg weighing dog, it will be kept inside the cage, and they will not allow us to take any blood from there. They will not present the dog for blood donor as a dog donor. They will not give. At least I should get a 500 ml blood. For that also I need a dog which is above 50 kgs. Now where I will get? This can be the blood smear, the spherocytes you can see. The slide glutate test positive. We need 750 ml of blood, at least 500 ml. We need a donor of more than 55 kilogram body weight. From where I will get a 55 kilogram body weight dog? We have to take the blood, and I have no time to wait also, because the ongoing severe intravascular hemolysis is going on. I am just going on with the corticosteroids. In that time, I cannot even control with corticosteroids. As an emergency measure, I have to get blood. We have to take blood from a single dog only, not from a second dog. That too, no second transfusion. Only one transfusion can be done. We know it. Only one transfusion can be performed. Transfusion can be done only once in the lifetime of this dog, because no grouping has been done. And if at all grouping is done, we don't know much choice of donors. The blood of the donor should be compatible to the recipient. If it is not compatible, to find another dog, which is impossible. We have no much time. RBCs are fast diminishing. Transfusion has to be done as soon as possible. I asked several pet parents. Dog above 50 kg were rare. He found the parent hesitated. Time is going. Running down condition. So I am forced to this. I am trapped. I should say I am trapped. What otherwise I can do? Time is going. Running down condition. Administered colloids, other IV fluids, and prednisone injection. Next day the patient became more weak, more icteric. The TLC was still normal. RBC was just 1.7. Hemoglobin was 4.1. Total bilirubin above 9. Bilirubin is again racing. Unfortunately, the creatinine shot up to 6.3. What I can do? I was in a hurry. I was really perplexed. Phoned to at least 25 people, but there was no response. Patient became very weak and extensively icteric. No time before me to spend. After 3 days, I got a dog of 45 kilograms. After 3 days, parent was willing to donate some blood, but very far, and they will come out the next morning. But that day evening, the patient collapsed and died. What to do? Being just a human being, what can I do? Where is the fault? I was really helpless. The pet parent with his family rushed at me. He abused me a lot and he tried to assault me, for which I was even not responsible. So in this case, what I can do? I could not do anything at all. You can imagine my situation. I could not do anything at all. So that was a case which I never forget. And with this, my dear friends, Bharat Mata Ki Jai, long live our nation. And so, my dear friends, I am concluding with this slide, and thank you very much for listening to my webinar. Namaste. Thank you.